Good morning. I'm Staff Sergeant Solomon Morgenstern, and today I want to talk to you about treating combat casualties. Casualties on today's battlefield that receive pre-hospital care have a better than 90% chance of survival. The pre-hospital care that we teach nowadays is called tactical combat casualty care. And it's that tactical combat casualty care that is granting these casualties a better than 90% chance of survival. I want to show you today how to rapidly assess and talk about treatment of a combat casualty using the principles of tactical combat casualty care, or TC3 for short. So I'm currently a military instructor for the Soldier Medic Training Site at Camp Bullis, Texas. Here at Camp Bullis and Fort Sam Houston, also in San Antonio, Texas, is where we teach all of the Army's medics. So this is the home of Army medicine. This is where advances are made in combat casualty care. I will demonstrate a rapid assessment of a casualty using the MARCH acronym, which is part of Tactical Combat Casualty Care. The initial phase, called Tactical Field Care, in which we treat life-threatening injuries before moving on to further stabilizing the casualty for movement, say, to a hospital or elsewhere. The MARCH acronym is M, massive hemorrhaging, A, airway, R, respirations, C, circulation, and H, hypothermia. And it is placed in that order because that is the order in which most combat casualties will die. So the massive hemorrhaging is the #1 killer of combat casualties, followed by airway issues, followed by issues with respiration, followed by circulatory problems, and then followed by hypothermia caused by hypovolemic shock and other concerns. Now, based on the MARCH acronym, the first thing I'm going to be checking for with this casualty is massive hemorrhaging. While I'm doing that, checking for massive hemorrhaging using a technique called the blood sweep, I'm going to check my casualty's level of responsiveness. And I'm going to simply do that by tapping him and prompting him verbally. Hey, are you awake? Are you okay? Can you talk to me? By doing this, it's going to let me know a lot of things. This casualty may have suffered traumatic brain injury. This casualty may be suffering an altered level mental status due to hypovolemic shock. It's going to give me a lot of information simply by whether or not they can respond to me. Then I'm going to go into my blood sweep. The blood sweep is using my hands to sweep different parts of the body, and each time I do so, I'm going to look at my hands to check for the presence of blood, like so. Starting at the head, sweep behind the neck, sweep the head, look at my hands. Paying particular attention to what's called junctional areas. Junctional areas, like the neck, the axillary junctional area, or the armpits, then sweeping down the arms, feeling underneath the body, each time I sweep, I'm looking at my hands to check for the presence of blood. The inguinal area, or the groin, working my way down to the feet. If I find any bleeding, I will treat it appropriately. I'm paying special attention to junctional bleeds, that is inguinal, axillary, or neck. These bleeds are difficult to control, and they tend to bleed copious bleeds, large blood vessels. They have to be packed with a hemostatic agent like combat gauze, and then wrapped in such a way as to hold constant, deliberate pressure. Bleeding injuries that are serious or massive hemorrhaging that are on limbs are easier to control because I can put a tourniquet on a limb. I cannot put a tourniquet in a junctional area, and hopefully you don't try to put a tourniquet around the neck. It's kind of a common joke here. So that's M, massive hemorrhaging. Again, finding a massive hemorrhaging, I'm going to treat it right there, because massive hemorrhaging comes first in our acronym because it's the #1 killer of combat casualties. The next part of my acronym is airway. In order to check the airway, I can talk to the casualty. If the casualty is speaking to me, we know that they're able to pass air. The airway is what's called patent. It's an open airway. If they can talk, they can probably breathe. However, a lot of our casualties will not be conscious and they will not be speaking to us. So I need to open the airway manually and take a look inside. I'm going to do that using the head tilt, chin lift, and looking inside, checking the oropharynx, making sure that the upper airway is not blocked by the tongue, broken teeth, blood, vomit, or other secretions, or any other foreign bodies. If the casualty is suspected to have sustained serious spinal injuries, I'm going to use a different technique called the jaw thrust maneuver to look into the airway and verify that the airway is patent. If the airway has debris, obstructions, or other injuries that prevent this casualty from being able to pass air through it, I'm going to need to clear that out. At this point, the next treatment I might need to do would be called a cricothyroidotomy. You may have seen this in movie or television. Essentially, I will make a 1 centimeter incision vertically in the neck over the cricoid cartilage. I will then take my scalpel and make a horizontal incision through the rings of cartilaginous material directly below the cricoid thyroid membrane, right here. Through it, I will then insert a tube, secure that tube, and check for spontaneous respirations. That is, make sure the casualty is breathing on their own. If I have an open airway when I check, I want to go ahead and check the breathing rate, rhythm, and quality. That is, how fast are they breathing? Are the breaths regular and rhythmic? And are they breathing with a lot of effort? Are the breaths shallow? Are they full, deep breaths? So, doing my jaw thrust, my head tilt chin lift, looking in the airway, and I'm looking, listening, and feeling. I want to make sure at this point, as I'm moving into my respirations, getting that rate, rhythm, and quality of the respirations, that the chest is rising and falling evenly. So at this point, hopefully I have taken off any gear on the casualty so that I can see the chest. Now this mannequin is made up to have bullet holes in the chest. If I have uneven rise and fall, that is, one side of the chest is rising up when he's breathing or respirating, and the other side is not rising while they're respirating, there are other procedures that need to take place now. For a gunshot wound to the chest, I need to put what's called an occlusive dressing on the bullet hole. This could be something that's pre-manufactured. It's basically a plastic dressing that seals the wound to not allow air to get in or escape. What this is doing is stopping the development of an injury known as a tension pneumothorax. Once I've treated that bullet hole with an occlusive dressing, I would need to consider doing what's called a needle chest decompression. That's where I take a 3 1/4 inch 14 gauge catheter and insert it between the second and third intercostal space, leaving for 10 seconds and allowing trapped air to escape from between the pleural lining of the chest and the lung, which allows the lung to then inflate again. Remove the needle, leave the catheter in place. A good example of this, if you've seen the movie Three Kings, they use this technique to great success in that film. So now that I've covered massive hemorrhaging, we've talked about checking the airway and establishing a new clear airway using a cricothyroidotomy if necessary. Now we've talked about respirations, checking rate, rhythm, quality, treating any injuries to the chest that would prevent the patient from respirating effectively. The next thing we're going to check is circulation. I'm going to start checking circulation. I'm always looking at the color, temperature, and condition of the skin. By glancing at the color, temperature, and condition of the skin, and I can feel, I'm going to get a lot of indications or signs and symptoms if the patient is in hypovolemic shock. For example, if the skin is pale, cool, clammy, these are classic symptoms of hypovolemic shock. If the skin was flushed, dry, and hot, these are classic signs and symptoms of a heat injury, a serious heat injury. But the reason the skin is going to be that way is going to have something to do with the circulatory system and the circulatory processes of the human body. What I'm most concerned about in my combat casualty is hypovolemic shock. That is shock that is due to low blood volume. The low blood volume will likely be due to the fact that they are bleeding out of a serious wound. In other words, massive hemorrhaging. So yes, even though I call it circulation, I'm going back and I'm doing more work having to do with bleeding. So with circulation, one of the good indicators for my patient's status I can discover by checking for radial pulses. Radial pulses, as the name implies, are located near the radius on each arm. Now, if my casualty sustains severe injuries to that area of the anatomy, I'm going to have to check elsewhere. But by checking bilaterally for the presence of radial pulses. This gives me a lot of information about the patient's perfusion and blood volume. If I have radial pulses, generally speaking, my casualty has a systolic blood pressure of around 80. Anything under that, and I'm very concerned about the effects of hypovolemic shock. With a systolic blood pressure of around 80, it's a good sign because my casualty is able to perfuse the tissues, that is, blood and the oxygen that the blood carries is getting to the tissues, and the casualty is going to be able to maintain their life. I have to make sure, however, that the process of bleeding has been stopped. If I don't stop the bleeding and I have radial pulses right now, which means I have a systolic blood pressure of about 80, and I don't stop the bleeding, a couple minutes from now I will no longer have that blood volume. I will lose radial pulses. With my casualty, if I have radial pulses, so I'm checking for about 10 seconds, if they are present, this is an indication for me to go ahead and initiate IV cannulation. So basically, I'm going to start an IV and put in place a saline lock. That saline lock will be there for the future for different treatments I may need to do or any uses I may have for it with this casualty. If my casualty does not have radial pulses, or they're very weak and thready, and they have an altered mental status, that is, they're groggy, confused, not responsive, or unconscious, this indicates to me that I'm going to need to do direct IV cannulation. That is, I'm starting an IV, I'm going to start a saline lock, but then I'm going to also initiate a couple different other treatments. With that saline lock in place, I'm going to push a medication called TXA. Now, this is a medication that prevents the breakdown of clots in the blood system. The bloodstream. Once I've administered that medication, which takes about 10 minutes, I'm going to come back and I'm going to start initiating 500 milliliters of whole blood product, which is the preferred fluid resuscitation medication. If I don't have whole blood product with me, which logistical concerns with maintaining whole blood products might prevent me from having them, I'm going to go with something called Hextend. Whether I use whole blood products or Hextend, I'm going to push 500 milliliters through my IV, and after the 500 milliliters of fluid has been pushed, I will come back, I will reevaluate my patient's circulatory system by checking for those radial pulses again. If I have an improvement, I should see the reappearance of radial pulses, or they should become stronger, and hopefully my casualty, barring of course any traumatic brain injury or concussive event, my casualty will start to come to, so to speak. I will have an increased level of consciousness and responsiveness. If I do not get this kind of response, I need to initiate another treatment or dose of TXA, followed by another dose of whole blood or Hextend. At this point, I'm becoming very concerned, of course. I may not have treated all the bleeding appropriately, or I may have bleeding somewhere where I haven't seen, that is, internal bleeding. In either case, this casualty needs to be gotten to definitive medical care, that is, a hospital facility or surgeon. If I do check radial pulses bilaterally in the circulatory phase of my MARCH acronym, and I don't find them, I do want to go ahead and check again for carotid pulse. And all this is doing is verifying that my casualty is still with me. If I don't have a carotid pulse, as you can imagine, my casualty is probably dead. So we are going to verify that. Oftentimes on the battlefield, we will have more than one casualty. If I have several casualties and I do not feel a radial pulse, and I go back to my unresponsive patient and I cannot feel a carotid pulse, I'm probably going to move on from this casualty so that I can give my attention, my time, and medical care to those casualties that have a better chance of surviving. This, of course, is a little bit of triage. So when I've completed my circulation, I'm going to go into hypothermia. Now, on the battlefield, what this is going to involve is simply making sure the casualty is covered up, that is, putting clothing back on them, and getting a blanket of any sort. A wool blanket's good because wool will maintain body heat even when it's wet. We have what are called space blankets. They're foil blankets, they're shiny on one side, and they help to radiate or reflect the heat back to the body. If I do put a blanket on the casualty, I want to make sure that the blanket is underneath the casualty, on top of the casualty, and we want to tuck them in. We do not want to create a convection current of air going through the blanket that will chill them off more. Hypovolemia is a serious concern for any patients that are suffering from hypovolemia, that is low blood volume due to bleeding out. Blood is one of the main ways that the body, through the circulation of the blood, maintains its body temperature. If we don't have enough blood in the body, that is hypovolemia, then we do not have the ability to control our body's temperature. So hypothermia, regardless of the ambient air temperature, is a concern. I can tell you of one instance in Iraq in 2006 where we had a casualty who had bled out significantly, suffer from hypothermia while they were in the helicopter. It was 106 degrees outside and they suffered from hypothermia. So this is not a minor concern, this is a serious concern, which is why it is part of our MARCH acronym. So now that we've used our MARCH acronym to find and treat significant life-threatening injuries, we're going to go back and do what's called a detailed physical exam, find the smaller minor injuries and treat those while we're preparing to evacuate or transport this patient to a higher echelon of medical care, that is a hospital, a surgical facility. We would also consider pain management if appropriate. If we have an unconscious casualty, of course, pain is not something we're going to worry about at this point. The thrust of tactical combat casualty care is quick and dirty field medicine, save the life, get the patient out of there. So you may not be a military person, you may not be a combat medic, you may not even be medical at all. The good thing about tactical combat casualty care is that you have the experience of a couple of decades of from low to high intensity conflict and combat that has led to the refinement of this system or framework of giving pre-hospital care. It has become very, very efficient. Anyone can benefit from using the principles outlined and detailed in tactical combat casualty care. The most simple refinement of it, the simplest aspect of it, is this MARCH acronym. Using these principles, you can save a life. We all have family, friends, and loved ones. Most of us will at some point in our lives experience an accident or experience someone close to us having an accident. Most people know that they have a need to understand basic first aid. If you're going to take the time to learn it, why not take the time to learn the system that is used by the best combat medics in the world? The system that has benefited from centuries of experience in combat, especially the last couple decades, and been refined by the best surgeons and developed out of lots of experience.